So let me know when you're ready, and I'll introduce you.
Ready when you are, Curtis.
All right. Good morning, everyone. How are you? Hope everyone's having a great day. I know it's just a small bit of us today, but I think this is going to be an amazing event for CSCA and the Health Network that we are collaborating with today. So my name is Curtis Darragh. I'm the CSCA Middle School Level Liaison, and I'll be helping Patricia facilitate this. And we're so happy to have her here. She's going to talk to us about identifying early psychosis in adolescents. Given the COVID pandemic, there's a lot of mental health needs going on with our students across the state of Connecticut and across in the world. Advanced services for adolescents with psychosis or ASAP program, it might be good for us. It is going to be good for us to collaborate with Patricia Graham and the Hartford Health Network for the health and safety of our students. So Patricia, thank you so much for joining us.
Thanks for having me, Curtis. We've been very excited to offer this presentation to all of you because we all got to work together to help these kiddos, especially right now at this time. So thank you so much for having me, Curtis.
Yes.
So the way I structured this presentation is really to give you an overview of identifying psychosis in adolescents, because typically we talk about it in late adolescence and young adulthood. And our program really focuses on the 13 to 18-year-olds who are still very much impacted and often still in school. And then towards the end of the presentation, I'll talk more about our program and what that looks like and how to put in a referral and all of that. So I put a lot in here. So if at any time you have any questions, I did leave time in between the sections to allow you guys to ask questions. Feel free to stop me, especially since it's a smaller group today. So again, I'm just going to give you an overview of the presentation. We're going to talk just a little bit about the history of schizophrenia and psychosis. We're going to talk about identification, differential diagnoses, treatment, and then the ASAP program. So just to give us a little history lesson of schizophrenia in general, that it was actually in the late 1800s that we really identified what schizophrenia was. It was believed to be a dementia precox or premature dementia. And they really described it like OCD-like symptoms at the onset. And keep that bullet in mind because that's something that we're still seeing now. And it was really the Swiss psychiatrist, Dr. Bleuler, who coined the term schizophrenia, which in Latin means split mind, over a century ago. And he was also the first one to describe the difference between positive and negative symptoms in that presentation. Of course, the treatment was not really humane for this population about a century ago with shock therapy, lobotomies. And it really was in the 50s where we started to look at pharmaceuticals. Thorazine, which was actually for anti-vomiting, was found to be helpful for this population for psychosis. So I'm a mental health first aid trainer in addition to my role as a clinician. And this is from the older version of mental health first aid. The newer version just came out, but this is really what the public still believes about what psychosis is. They still think that it's a split personality. It's because you had a bad parent. That person's dangerous. And that really comes from prejudice, very much misunderstanding and ignorance of psychosis and just not knowing about it. And this is something we continue to have conversations with our families about because that's still very much their perception of what psychosis is. So just to give us all a reminder of what psychosis is, it's a cluster of symptoms where someone has had a break in reality, and it includes both positive and negative symptoms. The positive ones are those typical hallucinations and delusions, and the negative affect can be that flat affect, thought blocking, latency in speech, and those 5 A's that we look for. In adolescence, we typically see more of the negative symptoms, and we'll talk more about that in a little bit. And it can be associated with multiple different diagnoses. We see it within major depressive disorder, we can see it within bipolar, and also a schizophrenia spectrum disorder. So this is a graph I'm going to show you actually multiple times throughout the presentation. It's one of our favorites, and we actually show it to our families. But this is really what we're looking at in terms of where schizophrenia starts. And this late at risk of psychosis state is actually before the first episode of psychosis. and we'll talk more about what that is. But the population we work with like the 17 and 18-year-olds, we see more of the first episode. They actually are experiencing that. But there's also earlier signs of the prodromal phase, and that includes the brief, limited, intermittent psychosis episode, and also the attenuated positive symptoms that we might see as well. So prodrome, meaning that it is a forerunner of an event. It's the prodromal phase. It started actually in the 70s and 80s, and it really boomed in the 90s in Canada and Australia. It came to us in the United States more in the early 2000s. And it's now, all that work is now what we see as the first episode psychosis programs. And now we're starting to look before the first episode, which is our clinical high risk, which is what we see within the teens. So again, just to give you a update of this, and I want to also highlight the prevention part on the lower part of this and the treatment, that a lot of the work we do is prevention for this population as they move into adulthood and experience psychosis. So some of the symptoms of the prodrome, I would say this slide really encompasses what you might see with teens, and certainly a change. So there might be suspiciousness where there wasn't before. They might have changes in appetite, and they might feel like their sense of self has changed, like something's up, but you can't always put your finger on it with seeing a change with a teen. I would say the biggest highlight is when we see a marked impairment in social functioning. So what we see in our program is a teen who was so social, had no issues with school, and all of a sudden now they're really struggling. They can also have a lack of initiative, and certainly that blunted affect that they struggle with as well. So clinical high risk, this is really the population of teens that we work with. It's actually still a fairly new concept, I would say within the last 5 to 6 years, and we're still learning so much about it. It's also known as ultra high risk. Don't ask me why they came up with 2 names for one thing. It means the same thing. And they're really behaviors or characteristics that indicate a change that they might be experiencing prodromal psychosis. They typically do present with more of those negative symptoms than those typical positive symptoms we see of psychosis. And a big indicator is difficulties with concentration or attention, especially when they didn't before. There's a lot of research on identification and very little on treatment of this population. So we're really good at identifying, but we need to do better at how do we treat this and how do we actually prevent it while treating it. And we continue to have challenges with screening. As we know, working with teens, there's lots of different factors going on. They live with a family, they have grown-ups, there's lots of different things going on. So we need to really figure out what they're experiencing and how that impacts them. So this is just another graph for all of you of the development of psychosis. And a lot of the work we're doing is this prodrome or pre-phase before they experience that first episode psychosis. First episode psychosis can be traumatic for people. It oftentimes can lead to hospitalization. And so we really want to try to reduce that happening for these teens. And again, just this slide, just to reiterate and kind of give you a mental picture of what we're looking at. So these are just some of the criteria for the schizophrenia prodrome, the attenuated and basic signs and symptoms. And so you can take a look at it. We can actually diagnose this with the new DSM-5 under other specified psychosis, and just we make a note about the different types of it. So when we're taking a look at these teens, the differential is very wide, and we keep a lot of things in the back of our head. First and foremost, as with anything, we always want to rule out medical causes. I can tell you that we've had a few cases where we had teens who experienced temporal lobe epilepsy. And looking at this teen, he really looked like he had schizophrenia. He experienced all the symptoms, he met criteria, but after sending him to a neurologist, getting additional testing done, no schizophrenia whatsoever. It was all his temporal lobe epilepsy. And this particular teen was terrified of having that diagnosis because of the stigma, but we really always want to rule that out. Encephalitis, tumors, acute exposure to substances or toxin, we always want to keep that and rule that out. We get a lot of referrals of teens who maybe just experience visual hallucinations. Typically, if it's just visual hallucinations, they don't have any of those negative symptoms. That's typically more indicative of PTSD. Dissociative disorders as well. OCD disorder can, on a very severe side with their negatives or their negative thoughts, can be perceived sometimes by the way the teens describe it as auditory hallucinations. So of course we want to rule that out. Bipolar disorder, of course, or an emerging, and autism spectrum disorder. And we'll get into some of the co-occurrence that we see, but sometimes that can also look like psychosis. We've had some others who present with psychosis, but really when we take more of a look, they actually are experiencing a fictitious like disorder. So it's important to talk about very early onset schizophrenia, which does occur, but it's so incredibly rare. This is when it's under the age of 13, they do experience those hallucinations and delusions. So that's really the difference, where the prodromal teens over the age of 13 have more of those negative symptoms. These experience more of those positive symptoms. It's 1 in 30,000, so it's very rare. And the premorbid symptoms before they become ill, they do include some developmental delays. Sometimes they're often misdiagnosed with ASD before they experience those psychotic symptoms. And the earlier the onset of psychosis, especially with this group, the more challenging and disabling it is for them as they go through the course of their life and move into adulthood. And these individuals carry a much heavier genetic predisposition than maybe others might. So these are some of the co-occurring disorders that we see. Substance use disorder, of course, which I'm sure that all of you see with the teens in the schools. We do see a lot of marijuana causing psychosis, especially if it's the synthetic vaping. Autism spectrum disorder, we see a lot of co-occurrence with that as well, and obsessive compulsive disorder as well. So these are some of the screening tools that we use in our program and use throughout the world actually for identifying at-risk psychosis states. So one of the biggest ones, the bottom, is the SIPs and the SOPs. That's something that a lot of the psychologists use to be able to test for these at-risk psychosis teens. So medication, of course, is something that is important to talk about when we think about psychosis. Of course, positive symptoms, there are more medications that help with these. And unfortunately, with those negative symptoms, there's not as many resources or medications that help with these. So we really try to use that with different types of treatment. And I'll talk about that in a little bit. So how does psychosis affect the brain? We know that psychosis is a brain disorder. It affects the brain. So this was done about in the early 2000s, I believe. This is a brain scan post-mortem. On the left is somebody without schizophrenia, and on the right is somebody with schizophrenia. And just to highlight, the cavity in the middle of the brain is much larger. And if you take a look on the outside of the brain, there's also erosion as well. The more a person experiences psychosis, there's microscopic damage done to the brain. So it's super important that we address this as early as possible to reduce the amount of episodes and the amount of damage done to the brain. The other part, interesting part on the prodromal phase of the brain impact is neural pruning. So this is a pictures moving from the left to the right. The left is birth. So these are the neurons in our brains. There's really not a lot. By the age of 6 years old, there's so many in there. And then by the age of 14, which is the population we're talking about, the brain starts to prune those neurons based on what that person needs. So why? Why does our brain do this? It's very important for brain function. It's almost as if there are too many tabs open in the brain. So the brain takes away what the person isn't using. And when we think about somebody who's experiencing at-risk psychosis and they're not using those social interactions, they're not using their brain as much because they're struggling with concentration, it's getting rid of those tabs. And so if they're not using that skill, it gets rid of it. And this is just for efficiency of the brain. So what do we do about that? Well, unfortunately, sometimes the brain prunes too much and sometimes not enough. So when it's too much or too little, which can happen with our population, they can experience difficulty with focusing, they can have their mind wander a lot, and they can be too tired. And I just want to point out, these are not my slides. These are Dr. Choi's slides, who's our neuropsychologist, and he thinks he's the most hysterical person ever. So neural pruning, not enough, which can also happen with our population. You can see this wheel with all of the symptoms we've talked about already. And of course, that biggest one is disorganized thinking. And that's really what happens when there's not enough neural pruning. And again, this is just a visual of what we might see with the teens, the young adults and adults when there's not enough neural pruning. And again, this is the presentation we see. This is how we see them function or not function. So of course, we see substance use with psychosis. We're seeing more of this in adolescents. I can tell you in our program, we're seeing sometimes teens experience psychosis 4 to 6 months after they've used based on the toxicity and if it's laced, which can make it very difficult to identify if this teen is actually experiencing psychosis of early onset psychosis of a schizophrenia spectrum or bipolar. So it takes a lot of time to be able to rule that out. Some more recent literature in the last year has suggested that the vaping marijuana can actually trigger psychosis. There's other research that just came out that says for adults, psychosis can actually help, or marijuana can actually help people with psychosis. So it's a little bit of a catch-22. So conversion, rate of conversion is something we always want to talk about, especially with our population. It's a newer concept, but when we think about hope, there's still so much stigma about psychosis out there. 50% of people who experience psychosis in adolescence will go on to develop a schizophrenia spectrum disorder. 25% will go on to develop a serious mental illness like bipolar disorder. And then 25% of it grow out of it. They never experience it again. And this is something we often share with families because this could be the only experience they have and they could never experience it again. So I just threw a lot of information out at you in terms of identifying this group. Does anyone have any questions before we start talking about treatment?
Patty.
Yeah.
I'm wondering if you have the time, it might be helpful if there was a way to like describe maybe one of the teens that you have treated and seen this transition just for a real life, for people to be able to kind of say, oh, that sounds like so-and-so or.
Sure. Would that be helpful for everyone? Okay. All right. So, we have so many teens. Let me think of one. Okay, so we just had a teen who discharged. He came from inpatient. We often get a lot of our referrals from inpatient. We're the only intensive outpatient program in the state who works with this population. Others are clinics. So this teen struggled with his education. He really had a hard time focusing. He was never really engaged in school. School felt like he was on the autism spectrum. He was just never really present in school, and school really wasn't sure what to do with him. So he came to our program quite heavily medicated, but really engaged in program. He experienced a lot of the auditory and visual hallucinations, although he also experienced a lot of those negative symptoms. He had a very flat affect, It would often take him 2 minutes to answer your question. He oftentimes did not seem mentally present. Family would have a really hard time communicating with him. He really didn't want to shower. It was really hard for him to sleep during the night because he was so afraid to go to sleep at night. He was worried about his auditory and visual hallucinations. So he would sleep through the day, which often meant he missed school. So he came to our program and just discharged. He was with us for about 6 weeks, and we were able to get him back into school. We got his sleep back on schedule so that he could attend school. And he really needed a lot of structure in his life. So, you know, you need to go to bed at this time, you need to wake up at this time. So a lot of times with our teens, we do some of those basic skill building, like you need to go to bed at a certain time, wake up at a certain time, have some sleep hygiene, take your medications at the same time every night. Those were the types of things that we did with him. So he actually did meet criteria for brief limited intermittent psychosis syndrome, which has a higher rate of conversion to schizophrenia. When he came to us, he had no friends. He never socialized. He really never left the house unless he went to school, and that was pre-COVID. But through our group, he was able to socialize, have more friends. I think he was even trying to get into dating by the time he left. But just a really unengaged teen. And even though he struggled in his educational forum before, he was actually always a really social kid. So there was just this huge change for him. Does anyone have any questions or concerns? Or I could give another case if people would like. Okay, I'm going to move into the treatment phase. So I'm going to give you an overview of what the treatment typically looks like, and then I'll talk more about our program. So with psychosis, a coordinated specialty care model really works to really just wrap around these teens and young adults. And I'll show you a graph in a minute of what that looks like more. Cognitive therapy is really important because of the brain impact that it has. And of course, skills are important. Low STEM groups or low STEM environment can be really helpful for these teens and young adults because they have so much internally going on. Psychoeducation, of course, is important. They have to be educated about their illness and what's going on and their symptoms in order to be able to function and know when maybe they need more help. Vocational and schoolwork. So we're a smaller track within a larger general PHP IOP for adolescents and children, and we do a lot more schoolwork. I talk to our school counselors and school clinicians that are working with our teens almost on a weekly, if not a couple times a week basis, just because these kids struggle so much. So collaboration is really important. Cognitive remediation, which I'll talk a little bit more about, but it's basically video games that exercise the parts of the brain that are affected by psychosis. Mental flexibility is also really important to be able to help them problem solve. And family education and support is always important when we're talking about psychosis to, again, support that teen or young adult. So the coordinated specialty care program or framework is recovery-oriented treatment for people with first episode psychosis. Lots of other programs utilize this model as well, but it really promotes shared decision-making and uses a team of specialists with different disciplines that work with a client to create a very personalized treatment plan. And this is just an example of what a CSC looks like. So we have the medications, case management, resiliency training, support, education, and employment, peer support services. Having a peer specialist is awesome. And of course, that family education, and that really encompasses the specialty care model. So of course, medications are important. Dr. Zajac, our psychiatrist, was going to join us, but unfortunately she's out sick. Hopefully she doesn't have COVID, but now we're getting into flu season, so we never know. But really, just briefly, there's the old antipsychotics and new ones. I'm not going to go much into medications because I'm not a provider, but both of these are still very much used. And you can see a timeline from the 30s all the way up until the early 2000s, about 10 years ago. Not much has changed, but the different types, the first generation and second generation of antipsychotics, most of the providers I know and work with, all of them really try to help that individual with the symptoms they want help with, while also trying to balance the side effects, because we know these side effects are really, really challenging for all of them. So CBT for psychosis is another treatment modality for this population. There's also a CBT for clinical high risk as well. That one has not been researched as much as CBT for psychosis, but a lot of programs are incorporating this. We do a little bit of it, but it really just helps them feel heard, identify their triggers, help them cope, and understand their delusions are not reality. So doing a lot of reality testing skills. And a lot of it is engagement, befriending, assessment, formulation, intervention, and skill building, and just consolidation of skills. Very, very much CBT framework. But we found it to be really, really helpful for these teens, especially when they are experiencing their first episode. So our program stands for ASAP. It used to be called Connecting Adolescents with Psychosis, but sometimes people would joke, it sounds like you're giving kids psychosis. So we definitely didn't want to give that message. So we recently changed our name about a year ago. We are an intensive outpatient program within a larger general track PHP and IOP. The average length of stay is actually 4 to 6 months, and we slowly titrate down the days. Typical PHP IOP is 6 to 8 weeks. So I think that just really speaks to how much support these teens need. We do mainly group therapy. We do a lot of family therapy, individual check-ins. We do at-risk psychosis testing, which is part of our program. And we also do socialization and school advocacy and collaboration with any other provider that the individual or family feels we need to do. Our team includes a psychiatrist, her name's Dr. Zajac, myself as a clinician, and then we have a phenomenal caseworker. Our caseload is 8 to 9, in the general track it's 10 to 11. So we do a 4 to 6 week assessment period. A lot of that is getting to know who the teen is, getting to understand the bigger picture, collaborate with outside providers, gain collateral as much as possible. If the teen has ever had any testing, we try to get a copy of that, just to really sit down and figure out what the history has looked like, to figure out what their diagnosis or their functioning is now. This also includes testing with Dr. Choi's team. So his team comes in, they do the at-risk psychosis testing. Once we get the results of that, we do an open dialogue forum as a family session to involve ourselves, the testing team, and the family and the teen to be able to give the results of that testing. We really instill a message of hope whenever we give the information. In the a little over 2 years I've been here, we've given a diagnosis of schizophrenia 3 times. So it's really not often that we give a diagnosis like that. If we do, it's often in the almost 17, 18-year-old population. The rest, we really give the at-risk psychosis diagnosis. Again, we do group programming, we do cognitive therapy, a lot of psychoeducation and low stimulation groups. And honestly, a lot of the skills groups we do are also adolescent development appropriate. So again, sleep hygiene, relationships, how do you balance school program, how do you balance being a teenager? That's really difficult. So we try to balance both the psychosis they're experiencing, but also what it's like to be an adolescent and how challenging that can be. Of course, medication management, we do a lot of family therapy. When a teen starts, we often talk to the family almost every other day, especially if they're acute and they're just coming out of the hospital. We do it once a week for about a month and a half with the family and the teen, and sometimes just the parents as well. Oftentimes we get families who have experienced challenges with navigating the system, or they've experienced trauma because of the system. So a lot of the treatment we do is also towards the family. We do cognitive remediation. Those are the video games I briefly talked about, and I'll talk a little bit more about. And we also do mental flexibility. These teens oftentimes have a really hard time problem solving and having lack of insight. So some of the mental flexibility conversation is facial recognition. How do you know if someone's mad at you, or what's your perception of that, and having a conversation about that. We also offer a multi-family support group for both previous families who are in our program and current ones. And we did that after a family member had left our program, and she was like, I don't feel like I have a forum to talk to other people who have experienced what I have experienced. And so she was like, have you guys ever thought about providing a support group? And so we did, and it's pretty well attended, even with people who've left us over a year ago, because unfortunately these families don't always feel like they can talk with others about their children having psychosis. We are mainly clinical. We do not have research criteria or anything like that. We don't have a catchment area. We are self-funded. We are a part of some research opportunities, but that is only if the teen and the family want to participate in that. So a little bit more about the cognitive remediation, which is the video games, and it really stimulates the parts of the brain that are affected by it, the processing speed, and just rehabilitation to impact the areas that have already been affected. So processing speed is very much part of being affected when it comes to at-risk psychosis. And we just have this visual that the processing speed leads to broader cognitive domain skills and mental flexibility, which also affects their functioning. When we think about all the protective factors for this population, social functioning and social interaction is actually one of the biggest protective factors we found. So again, cognitive stimulation keeps the mind active. They do puzzled. They're really hard games. I don't know if anybody has ever done Lumosity or any of those brain games, but you can do those, and it exercises the parts of the brain, whichever one you want to work on. But these games are really hard. We've sat down and done them. And the cool thing about ours is they do it on tablets, and the video camera actually measures their pupil size to make sure that it's not too hard and it's not too easy. So it's appropriately challenging them. And again, it's just drill and practice, continue practicing to affect their information processing speed and target those neural connections so there's not as much damage done. And these are just some of the different types of games that they can do. And lastly, it's a group therapy that instills an understanding of how the brain works and cognitive strengths and weaknesses. And it also teaches those cognitive strategies of how to pay attention to details, problem solving, and body language. So these are just the two research opportunities that teens or families can be part of. So we're part of the Boston's EPIC Center research study. And also more recently, the Psychosis Risk Outcomes Network, which is an international study we just joined of 27 sites around the world, which I think is 3 to 5 years, which is also includes NAMI and the FDA as well. So those are research opportunities people can join if they'd like. So these are just some of the quotes that we have of families. The stigma is so much very real. When we've given a diagnosis of schizophrenia, we've heard, I feel like you're telling me my son has cancer. You mean he'll have to be on medications for the rest of their life? That's not always true. What will this mean for them growing up? And what did I do wrong to make my child to have this? So these are things that our families have told us. And so again, we really try to provide as much education as possible to reduce the stigma out there, really instill hope and recovery. We still get emails from teens a year or a year and a half ago. Families send us their graduation pictures or their college acceptance letters. So hope is a big message we always want to portray to the teens and also the families. And again, just the recovery, only 20% of those who experience clinical high risk go on to develop a schizophrenia spectrum disorder. And schizophrenia does occur in thirds. So only 1/3 will have a psychotic episode in their life. Another third will have a few, but are pretty well in between. And that last third are, I think, what most people associate the entire general population with, that they have multiple psychotic episodes and are not well in between at all. So how do you send a referral? I think earlier this morning, I sent Curtis a bunch of information. I sent the referral form, our brochure, and the PQB21 screener, which isn't the best, but it's what we have in both English and Spanish. So you can call our assessment center, and you can see the number up there. Typically, we ask for the referral form to be filled out and the PQB21 screener. The screener is, again, it's not the best, but it's for the teen to fill out on their own to help us identify where they feel they're at with their symptoms. We really work with teens. We're not a mandated program. The teen really wants to have to work on what they want to work on, but we really try to work with them on what symptoms are you experiencing and how distressing are they, and is it impacting your functioning? If a teen, likes their auditory hallucinations and it's not impacting their functioning, who are we to say that they need to go away? So we really try to have that recovery-oriented approach. And feel free to call me, email me. If you have a case you're really not sure about, myself, Dr. Zajac, we are more than willing to talk to people and just have a conversation about these kids. They're complex. They're complex for us too. It takes a long time to really figure out what's going on with them. So we're happy to have conversations. If you're not sure about sending a referral, we'd be happy to talk with you about that. And these are just some of the references from the presentation. I also sent this list to Curtis as well. These are really great articles. And Dr. Choi put those together for us, and he knows everything about schizophrenia. So he's up on the literature as much as anybody. So I threw a lot of information at you very quickly, but certainly I'll stop sharing my screen. If anyone has any questions or concerns, I'd be happy to talk with you guys.
Patricia, thank you so much on behalf of CSCA and everyone here today. That was a lot of information, but I felt like it was a good wealth of information. And for people who weren't here today, this was recorded, so this can definitely go out to all of our members. I just had a question about insurance. Is Husky something that you guys take? Because I know in Danbury, that is a very popular insurance that a lot of our families have.
Yes, we do take Husky. And actually, the wonderful thing about if they do have Husky is there is a first episode psychosis intensive case manager who we work closely with. The previous person just retired and the new one just came in. They work from 16 to 26-year-olds. I'm really trying to get them to go lower in age, but they're phenomenal. They also have a peer specialist. So we love it when they have Huskies so that we can provide as much support as possible. And a lot of our teens for transportation, we use Veo. Unfortunately, we have the majority of our caseload right now, more than half of them live an hour away and they drive an hour to come to our program because we're the only one in the area.
Wow, that is definitely beneficial. And where in Connecticut are you centrally located for everybody, or do you have multiple branches?
We're in Hartford.
Hartford, only in Hartford. Okay.
I wish we had multiple branches.
Centrally located.
Yes.
For the state of Connecticut. Okay.
You answered my question because I'm in Fairfield County. So looking at like Curtis, looking at areas down in this area, but you said they come from an hour away at least. So being the only one, it's good to have that resource available because there's a couple students that I'm questioning right now. Does a student, I have one particularly concerned that was doing okay going out, and this could be COVID related too, but has almost had I consider kind of a mental breakdown. Is now we're seeing depression, school avoidance. It's tremendously difficult. Didn't have a lot of friends before that, could be in that kind of quirky category. Is that 12-year-old, 7th grader? And the answer now is a 504 plan, but we've watched this tremendous drop. Was on an upper level academically, and is basically kind of slid right off and doing nothing, no motivation to do anything, difficulty getting to school. So now has put him into a bridges, like junior bridges type program, which is kind of a self-contained, but I'm not seeing, and I don't run that program. It's under our special ed, but yet he's not a special ed student. So I'm worried because I'm not seeing any progress. I'm worried about some other personal things that aren't happening that we would like to see happening, like not just the person doing the testing, but more of a therapist that's working with these types of things. So I don't know, suggestions would be, you said a screener, you had a PQB screener for that. That like just red flags right there. I'm like, is that something really we should look at that maybe would give us some information? But is that in the school's realm? Should a school really be stepping up to do that? Good morning, everyone. Sorry, our announcements are on now.
That's okay. I was going to say, Dr. Thomas, I think that, the screener is a really valuable resource just to get a sense of what they're experiencing. I can share that COVID is making this even more complex. And I think your case is a really good example of that, of these teens that maybe were on the fence, but not so much. And now they're withdrawing so much. It's really hard in our general track, and Ari is on the call, but we have a wait list of 8 to 9 kids in our general track. And a lot of it is all these kids are coming in back into school and they're having agoraphobia, and it's just really challenging. The suicide risk is up as well, which I'm sure you're all aware of. So it's a challenging clinical picture, but I think that, and I obviously can't answer about the school thing, but I think that screener, share that with everybody, and it tells you how to score it. I think it really gives you a good sense of where is this teen experiencing symptoms, if at all, and if they're distressing.
So you're saying it's not unusual for this student to be academically, was doing well at one point in time, and that's, now is like totally lost and in that. So it's not unusual to see that in this case. Okay.
Yeah, definitely. I think sometime right now, COVID's complicating that a little bit, because kids that never struggled before now are, whether it's anxiety or depression. But in my personal opinion, why not screen them? You'd rather screen out psychosis and make sure it's not there, so that we're not missing it.
Thank you.
Thank you.
Very good questions. Is there any other questions from anyone on the call? Well, I definitely know that was a big wealth of information. And I know, Patricia, we have your contact information, and we can definitely, reach out, and we took some of your resources, and we can definitely blast that out to all of our members. I know I'm going to have questions later on. I'm just definitely processing a lot of what you stated. This is a great resource for a lot of our families, and I'm so happy to hear that Husky is an insurance that you take.
Yeah, absolutely. Yeah, we take all insurances, so that's never a problem. And we really try to work with people. Right now, we're 2 days in person, Mondays and Wednesdays, and the rest are all virtual. We did move to 5 days a week, and I think our brochure says 4 days a week, just to accommodate the school schedules of all the teens, so that they don't miss their in-person days. So, we're always willing to work with people. The family piece is really important. The family's got to be on board.
Yeah.
As teens come with grown-ups, and they need to be part of the treatment as well.
Okay, and I really like that family connectiveness too. It sounds like you work really collaboratively with schools and getting these families to get the help for their child in need.
Absolutely.
Curtis, you're going to share the resources that Patricia had available, because your PowerPoint was so overwhelming. I'm trying to write things down, so I have notes. I'm like, there's
Me
things
too. I was doing the same thing.
Right, I'm trying to say, okay, I want to go back to that and see where, the onset. I'm looking at these things. So Curtis, you have all the resources, and when the recording goes, is it a video recording, or just
yeah,
audio?
this whole Zoom was recorded.
Perfect. That's correct.
And
And you'll share those other materials that Patricia said she had available?
Yes, she gave me another wealth of information as well.
Awesome.
Too. So I know that the recording, once our webmaster from CSCA takes care of everything, that will go on, and then give a lot of other people for them to see the behavioral health network and all the resources that Patricia also sent over to. And I can also send those to you too, Pat, for myself.
Thank you. Thank you.
So you can get them right away. All right. Is there any other questions or any comments that were popping up from anybody? All good. All right. Well, Patricia, thank you so much for joining us this morning. With coffee and chat, I like to call it. That was really great. And on behalf of CSCA, I would like to thank you so much for joining us and giving us that information. This will definitely help a lot of kids, even considering the current circumstances that a lot of our families are in. So thank you again for joining us.
Thank you. And hopefully we'll talk with all of you soon.